All right, so welcome to part 2 of chapter 2 of the Plight of Appalachia for Scientist Pod. Part 2 is actually going to be more in depth about the opioid epidemic and kind of what policies could be put into place to help combat the epidemic, but not only that, to help those out who have suffered through it, help them and their families through it. So the last pod kind of left off at the beginning of the 2000s, kind of around 2005, 2007-ish. So that's really where this one is going to start, and this one is going to kind of dive deep into it. This pod, I guess I will give, obviously it says it in the title of it. This pod is going to talk about drugs, prescription opioids, and also a little bit, not much about heroin. So I guess I just want to shoot that up first so people know exactly what this is about. But it's also about what we can do, what needs to be done to help get this under control, because it has, there have been some, probably in the last couple of years, there's been some headway in the lessening of it, but it's still some of these numbers that I'm going to read out are very staggering. If you decide you want to watch these on YouTube, the YouTube channel is just managmentscientistpod. If you see me looking down or I pause for any amount of time, it is because I have some notes in front of me, because I want it to be, as accurate as I possibly could be. So starting back in 2001, doctors were required to really assess and examine their patient's pain level to make sure that it was significant enough to be put on these prescription opioids. So, or whether it required something more like a surgery or, the nerve blocking surgery, things like that. So in 2001, they were required to examine their patient's pain levels. In the mid 2000s, for any of you that are a little bit older or were, even a kid at that time, beginning maybe again 2005, 2007-ish, this is when they started coming out with those commercials about protecting your prescriptions from your teens. And really, it's because that was about the time that teens had started to steal their parents' prescription opioids from their medicine cabinets, and teens were starting to take them. So about that time is when those commercials came out. And, when I was about that time, I was thinking these are the dumbest commercials. Nobody's in there stealing heart medication, because I don't think they had good intentions, but I don't think they maybe presented it to what exactly those medications could do, or exactly what medications they were stealing, whether it was Vicodin or Percocet or Klonopins or any kind of prescription opioid that they could get a hold of. So then by about 2010 is when heroin kind of was introduced into the region. And like I said before, on the previous pod, heroin was actually a cheaper alternative for those who couldn't get their hands on the prescription opioids, or their prescription had run out. Heroin was a cheaper alternative. And here is where we kind of get into some of the, statistics on it. And this, I've just kind of done research in different, peer-reviewed journals. Obviously, I wanted them to be as factual as possible, but also I did a very large research / thesis type of paper for the MPA program that I'm in on this. So a lot of this is, it's kind of, in different places on the internet. But in 2013, there was almost 30,000 drug-dependent babies born. By 2015, there were 50,000 plus overdose deaths. And one huge thing that happened in 2016 was the Surgeon General actually made a statement saying that addiction was a disease. It wasn't a character flaw, and that it was about mental health. And that is a huge step in the right direction. Because again, I've said it before on this, and I will continue to say it on no matter how many pods I do about drugs. Addiction is a disease. It is a mental health disease, but it is a disease nonetheless. It's not just a choice. Like, yes, they may have made the choice to use that first time, but there was already some form of chemical imbalance there that led them to make that choice in the first place. So this was definitely a step in the right direction to help, lessen that stigma. And then as of, 2020, 2021, there are close to 150 opioid deaths or overdose deaths, not just by opioids, but overdose deaths per day. And one thing that I will talk about on here is also the use of Narcan. And there is another form of it that is one of the chemical elements of Suboxone. I will not try to pronounce it, but it's like Nalox or Naloxone. Both Narcan and this can be used to stop the process, like the chemical overdose in the body. They can lessen the effects of it. And I know that a lot of people have an issue with both of these drugs being free or being so readily available. But what you have to understand, again, addiction is a disease. Stuff like this needs to be around. What you have to understand is that no addict wants to get to the point where those have to be used. It's not like they wake up one day and think, oh, let me get to the point of ODing where somebody has to pull out the Narcan. When an addict overdoses, it's not a conscious, it's in a subconscious level. They're not realizing, they just want to keep taking and taking and taking to either ease the pain, make them feel good, erase whatever shitstorm is going on in their life. It's not this conscious choice of, oh, let me OD today. Nobody wants to get to that point. And for those people who are like, well, why isn't, insulin free? Why isn't, cancer treatments free? Yes, you should be asking those questions, but it shouldn't be of an either or. It should be, why aren't both? Which could raise the universal healthcare question, which I would definitely be a proponent for. We'll get into that part later. Some more staggering statistics, and this was something that I had to read more than one time because I thought that I had misread it. But in the area of Appalachia alone, there are 84 prescriptions per 100 people, not 100,000. That's per 100 people. So that's 84 prescriptions per 100 people. And again, I had to read that more than one time to figure out, like, to make sure that it didn't say per 100,000 or per 1,000. No, it's per 100 people. In the rest of the US, it's 50, like 58-ish per 100 people. So it's a huge jump from 58 to 84. That's 58 is even still a staggering number. That's 58 people per every 100 people, like per every 100 person. 58 of those have, an opioid prescription. But also too, with the more prescriptions that you have in Appalachia, overdose deaths are higher. They're 72% higher than the rest of the country. With this, with encompassing how are these people not getting the recovery they need? Why are they still on this? How are they not, how are they overdosing so badly? Like, what is the additional barrier? Like, what is stopping them from getting the help that they need? There's several things. There's lack of transportation, there's lack of housing, there's lack of access to the care that they need, there's lack of education, there is lack of steady employment, and they have a lack of a connection for long-term solutions, and a lack of being able to re-enter the workforce and the community when they're done. Really, it's just a lack of everything. They don't have the access. And this is, in some of the poorest parts of Appalachia, again, central Appalachia, eastern Kentucky, West Virginia, parts of Southwest Virginia. They don't have the resources, and they don't have places that they can go. Or even if they wanted to get into rehab, they have family that can't afford them to be gone, or, so the reason I didn't sort of add East Tennessee into this is because East Tennessee actually has, want to give major props to this. It's a nonprofit, but they also get, I guess they kind of get state assistance too. Not enough, I don't think, but there is a facility. It's rather large. They've got several different places. It's called Frontier Health. And they've done some amazing things to work with addicts and addiction recovery. They also do things like therapy for kids who've, gone through the foster care system, for kids who have been in abusive situations. They do a lot of work over a different spectrum, like a whole huge spectrum. They actually just opened not long ago a 24-hour crisis center. So that is like a huge, huge deal, because before they didn't really have, it was either you went to the emergency room or you went to another state-run facility that kind of didn't really have the resources either. And so they have now opened this 24-hour crisis center. And the other amazing thing about Frontier Health is they actually will employ addicts who have gone through their program to help out others, addicts who are wanting to go through the program. And it's just like, it's someone that I would like to partner with, eventually in the future to help my own nonprofit that I'm going to start. We can, help each other out, because like I said, Frontier Health has done amazing things, but they have a very serious lack of resources. I think that it's getting better, but they need more private donors. They need more state-run assistance. They need to be able to hire more people, especially with this huge crisis center. But they huge shout out. They have done a lot of amazing things. And I know a few people who work for them, and it's just like, they can't say anything. There's really nothing too bad to say about them. They take care of their patients. They take care of the people that work there for them. And, it's places like that are what we need throughout the rest of the region, throughout the rest of Appalachia, is places like that. Because right now, really, besides that, there are very few resources. Like, really the only things, and I'm not saying that these aren't, steps in the right direction, that these aren't what they need to get, off of the opioids to begin with. But really right now, methadone clinics are all, they kind of rely on at first. And, what methadone does is it's a synthetic, but it's related to opium. But it reduces the symptoms of their withdrawal, but doesn't give them that euphoric feeling. The other form is Suboxone, and Suboxone actually inhibits it blocks the effects of the opioids. Like, it blocks the pain relief and the feeling of euphoria. So those are two things that they can currently take. But in a discussion that I was having with someone else who has worked with rehabilitation centers, it's really just, it's treating the symptom, but it's not actually treating the full cause. Because really, again, addiction it's a mental health disease. So really we need to get to the epicenter, like to the real nitty gritty of what happened in this person's life, whether it be childhood trauma, whether it be PTSD, whether it be, some other form of mental health issue that brought the disease of addiction forward. And so that's kind of where I started thinking about what kind of policy I would want to write if I either worked with government or went into a position in government. And really one of the major policies I would want to write would be a social welfare policy. And that would entail getting, not only getting the individual suffering, the individual who was the addict, getting them monetary allocations for rehab, not only for addiction recovery, but also mental health rehabilitation, but also getting money for their family while they were in rehab, or getting money for the family for, whatever that they have gone through while this person was on, these opioids. But it's also getting employment services, once they've gone through recovery, helping them find the right type of employment. Because people know that once you've gone through rehab, there are a lot of places, like a lot of employers that don't want to, they don't want to hire recovering addicts. But not only that, there are places that could hire them that end up having the wrong type of management that is going to either make a triggering comment or make it so miserable for the person that it's going to trigger that mental health again, and it's going to trigger that imbalance again, and they can potentially start using. So really, the employment services is really going to detail what kind of job is this person going to be good at. I don't want to say vet out, but I guess vet out employers that are going to be good to these people, that are going to make the work environments, a safe place. And that should be true for everyone, not just addicts. That should be true for everyone. You should not feel like crap every time you go to work. You should not want to go to work. Most everyone has to work. Why can't you enjoy your job? In what world, in what part of being an adult does it have to say that your job sucks and you just have to deal with it? No, I don't think so. So yeah, having those employment services, also with that, making, housing easier to find, getting, vouchers for housing, getting some sort of transportation voucher, whether that be on a public transit if it's available, or getting them so much for an Uber pass, because a lot of them may not be able to have their driver's license back, but they have to have a steady drive to work. So if that's getting them some sort of Uber pass for, here's your monthly Uber allocation, it's going to get you to and from work. That's another part of it. Again, make sure they have a place to live. But this is also going to go into another portion, which is getting money for the communities, not only to build and maintain rehab facilities, but for the communities to make sure that the places that they build for housing are adequate, to maybe get some form of public transit, because that is a huge ordeal in its own. And I know in a lot of rural communities, it's not feasible. But definitely getting money to the community so that they can, have these facilities, because in a lot of these rural facilities, it's needed because the nearest rehab facility is too far and these people can't get to it. So that's part of the policy that I would want to, push forward and try to get on the agenda. And it's going to take a lot of work because social welfare programs are very hard. It's very hard to convince, the whole of Congress, both houses, that this is needed, that this is something that's going to work. Because with social welfare, obviously, your revenue does come from taxes. There are other ways to garner revenue, but it's also one of those things that you have to get private donors too for some of these, especially if they're nonprofits. You'd have to get private donors. So it's a lot of work. It's a lot of red tape, but it is something that the conversation at least needs to start. The other policy alternatives that I had, which are they're also needed, but this would be even harder to get through Congress, because one of them is having harsher penalties for big pharma for not being completely transparent on the addictive properties of any of the medications that they put out. Because I know that at the time when Oxycontin came out, before then, like I said, back in the 70s, they had, it was all this war on drugs. There was this big stigma about drugs. So they did have, they were very careful on who they gave the prescription to of Percocet and Vicodin. It was mainly to like terminal cancer patients. So it needs to either go back to that, and there needs to be alternative forms of therapy for people who've been injured, or pharmacists, like the big, not pharmacists, not local pharmacists, I'm talking about big pharma, the companies that actually put these medications out, or the people who, come up with it. They need to have, there needs to be some sort of repercussion or penalty if they don't state, hey, this is what this medication does. Here's the risk of it being habit forming. This is the risk, this is how habit forming it actually can be. This is who actually needs to have this drug. Like this is the level of pain that this person needs to be at before they prescribe this drug. Because I know that there was the family, it was the family that either came up with hydrocodone or Oxycontin. I know that they were they were under a lawsuit, I guess, for like putting the drug out on the market. The problem with going after big pharma is really that Congress is afraid to go after big pharma because of all of the kickbacks of all of the money. Because there are things that big pharma does that are, great, that are groundbreaking, like medications that they've come out with. But there also needs to be, more transparency. And I don't think that there's enough of that for these, especially drugs like this, where they get pushed out, very like significantly. Again, 84 prescriptions per 100 people. That number is, I can't wrap my head around it. And, but again, like I said, it's something that like politicians are afraid to go after big pharma. There are some that want to. I know that there's a handful that want to, but it would take the whole of both the Senate and Congress. It would also probably take, some executive power behind it, potentially even go into the Supreme Court to go after big pharma if they, continue to release, these different prescriptions that don't have full transparency of how addictive they actually can be. The addictiveness versus the actual benefit of the drug. There's also a policy alternative that I came up with myself, and one other person talked about this, was, we hate to say to penalize the hospitals and the doctors, because we know, especially through COVID, how much that they've gone through, but there needs to be some sort of penalty in place if a hospital, especially in these areas, that there is such an increase of, the opioid, like addictiveness, people who are addicted to opioids. There needs to be some sort of process of like, has this person, been an alcoholic, have they been addicted to narcotics before, their previous history. And I know that they're getting better at that, because I do know that, even with the methadone clinics, there has to be a certain process of who can get in. But they need to figure out, like, they need to find maybe alternatives for pain management, like there was before. Again, this could be a very big proponent of universal health care, because again, a lot of these people in rural Appalachia don't have health insurance, even through the marketplace, because they can't afford it. So for them, it's easier just to go pay whatever they can at urgent care. Not that, I'm saying there's anything wrong with urgent care. I go to urgent care when I need to, but they pay whatever they can and they get these pain pills. And it's supposed to be just this sort of magic fix-all, and it's not. But so those were two sort of alternatives to the social welfare policy that I come up with. Now in this, and not only in the paper, but this is how kind of, when policy is being made, there is like a selection criteria, a little bit of government 101 for you. When policy, before it gets on the agenda, when it gets on the agenda, there is a selection criteria before all of this. And that could be economic feasibility, which is there resources enough to support the policy? Are we able to get the resources to support the policy if there aren't already resources? There's social feasibility, which is how is the general public, which is, obviously people's constituents and their districts, how are they going to react to that policy? Which can also go along with political feasibility. Social feasibility could also be if there is a public vote on something, how the public is going to take it, how they're going to vote on it. They kind of really have to look at that. But political feasibility is obviously like how the politician sees whether or not his district, his state, constituents are going to feel about them bringing this policy to the front. With that, there also needs to be the politicians kind of need to look at it like, okay, how are my constituents going to feel? Is it going to get me reelected? I get that they look at it that way, but they also need to be like, well, is that enough, or do I need to do what's right? Kind of, is what's right outweighing what whether or not I'm going to get reelected? Because yes, you may live in a predominantly Republican area, and you do something out of the norm because you know it's right, and you vote with other Democratic politicians. Yes, the biggest portion of your constituents may not want to vote for you, but you may have gained a whole new group of people who want to vote for you, because you've gotten all these people who think, oh, what he's doing is great. And so now you have a whole new group of constituents, and you could still get reelected. So sometimes you kind of have to outweigh, oh, am I doing what's right? Versus, oh, is it going to get me reelected? Am I in danger of not getting reelected? Another criteria is obviously justice, which has not been in the forefront. We'll say that for the last, it's been longer than that, but mainly in the last administration. And what justice means is like, are the barriers going to be removed? For this type of crisis, it means, are the people who need the help the most going to have access to getting the help they need the most? Is it going to be available for everyone? Not just some, but for everyone? Are whatever barriers there possibly could be going to be removed? And again, this is one that there's been a lot of social injustice, and even with this kind of thing, the people who need it the most are the people who have the least access to resources. And that should be who's thought of in the very beginning. Like when this is all coming, it needs to be, yes, there are people in areas where there are access to resources that still aren't getting it. And they need help too. This should be available to anyone suffering through addiction. But we need to make sure that the people who need it the most have access to it. I'm not saying first, I'm not saying anyone's, yes, there are addicts who are worse off, but everyone needs to be able to have equal access to it. It needs to be equal. It doesn't need to be, oh, this rural community that we can't get anyone out to, is we're just going to forget about them. Because they're probably one of the ones that need it the most. They probably have, more like, it's just not as known because there aren't as many people, so it seems to be hidden. But we need to make sure that it's given to everyone equally. These resources are available to everyone equally. One of the next selection criteria is effectiveness, like how effective are any of these going to be? How effective is this social welfare program going to be? What are the criteria that they have to meet? Even if the person goes through rehab, even if you get them the resources that they need for employment afterwards, even after all of this, is it going to be effective? Are they going to be able to have long-term recovery? So that's another thing that's got to be thought of. Also, too, effectiveness going up against someplace like Big Pharma. Is it going to just be another slap on the wrist? And in 6 months' time, they're coming out with another drug and still not having complete transparency about it. So really, what would probably be the biggest option to help combat this would actually be a combo of all three. Really, that social welfare program to make sure that they have what they need afterwards, to make sure that they, have the recovery options that they need, to make sure that they're, able to get employment when they're done, but also to make sure that this isn't like a continuous cycle as far as like going after Big Pharma, as far as, implementing those penalties at hospitals for just, giving out prescription after prescription after prescription. And I know there's more to it than that. Again, it's not something that I would love to say, oh, it's the doctor's fault. Because again, it's not, like I said in the previous pod, the doctors get kickbacks, but not just for themselves, it's for the hospital. And I totally get that. But I do think that there needs to be some sort of eye opener to say, okay, wait a minute. Let's make sure that the people that are getting this are people who are going to be able to use it for a set amount of time. And they're not going to, not going to abuse it, or they need to have a more extensive history of who's being prescribed these products. With that being said, too, what's really going to help combat this too is not only the government programs, but also nonprofits. There needs to be more nonprofits that open up that are able to work with either state-run facilities or places, like I said, like Frontier Health, like the places that I want to open up, which are not quite residential facilities, but places that they can come where they have someone to talk to. I've, a few friends who are licensed therapists, one in particular who I plan on having on the podcast very soon, who would volunteer their time, who they have somebody to come talk to. They have a place to stay. They have a place to shower. They have a meal to eat. I also want to do things like this for the homeless population, but that is actually going to be another podcast that I'm going to come out with on how to help with the homeless population. But another thing that needs to be implemented that has been in several of these places, that's actually a really good idea, and a lot of people may not think of it this way, but there's needle exchange programs. I think they need to be started up just about everywhere, because not only does it get your dirty needles off the street, but it also protects people who are using those needles from getting something more serious. And it protects them from hepatitis, it protects them from HIV. Because I know people are like, well, they're choosing to shoot up. Okay, but they don't need to have that added disease on top of it. You know, they don't deserve that. Regardless if they decided to shoot up, they don't deserve that. So needle exchange programs are there to help, and we need to have people who can volunteer in those needle exchange programs that are not going to be judgmental, that are going to understand, that are going to be 100% there to say, hey, give me your dirty needles. I'm going to give you a set of clean ones. If you need more, come back and see me. And that's what I want to start in other places too. You know, these people deserve a second chance. And some of them may have had second, third, fourth chances. And I realize that there are people out there who have been addicted, who have done terrible, terrible things. And this does not excuse them at all. In any way, shape, or form. This does not excuse them from the terrible acts they committed. But if they would have gotten, if there would have been access to the actual help that they needed, it may not have happened. Now, some people are predisposed. I really do believe that there are people who are predisposed to do things, and drugs is just added on top of it. Do I still believe it's a disease? Yes, but I believe that there's something else that's there, that they're just kind of predisposed to just being a horrible person. And sometimes it's not even people who've done drugs that are horrible people. There are others out there who have not done drugs who are still terrible, horrible people. Previous to trials that have happened shows just how terrible and horrible people can be for racial reasons. So, you know, again, there are people who've had second, third, fourth, fifth chances and who have, you know, maybe messed it up, but that doesn't mean that they don't deserve it more. They are a human being. It's not a character flaw. It's a circumstantial flaw of the disease that they have. It's, you know, not because of their character. I don't think that they chose to have this disease. And again, like I said, I'm not excusing anyone who's done anything. I'm just saying that they still deserve help. And maybe for some of them, it's prison time. You know, like I said, there are some that are just predisposed to just be horrible people, and drugs have very little to do with that. It's just how they are. But again, for the most part, especially for a lot of these very, very poor people in, you know, the central part of Appalachia, they're victims of the circumstances that they were put in. And I really think that there needs to be more done to help get them out of those circumstances and to help them have a better life, not only for themselves, but if they have children or if they have partners, you know, to help them have a better chance at life. So that is really what this is about. And this was really, doing this research on this epidemic was really part of what started the programs that I want to start, but it also kind of, I don't want to say that I'm going to run for Congress anytime soon, but if it will help to get these programs versus me just working for someone, being an underwriter in Congress, so be it. If it has to be, you know, I'll take that leap and I'll run. You know, I do have quite a bit of the qualifications needed, and you know, I plan on getting a PhD right after this, but really opening up that nonprofit and really starting to try to see a change, and also to end the stigma of talking about addiction and talking about recovery and talking about the fact that it's a disease and these, these people deserve, to get help with that disease is really a huge part of it as well. So if you heard purring and or if you are watching this on YouTube and you saw my cat, he decided that he wanted to be a part of this. I also have been fighting an ear infection, so I kind of sound a little rough. I apologize for that, but I really wanted to get this one up. The next two that I have planned, one of them, like I said, we'll be talking with a good friend of mine. I say good friend, she's my best friend, who is a licensed therapist, and she brought it to my attention. One podcast that I needed to do was how people who physically harm themselves, again, should have said trigger warning, gave a trigger at the beginning of this, but it wasn't for this. People who harm themselves for mental health reasons can be put on psych holds, but addicts that kind of do the same can be criminally charged, and that's ridiculous. They should be also put on psych holds versus just being thrown in jail. So that is one we'll be talking about. I will definitely put a trigger in the, if you're just listening to it, I'll put it on the podcast, like what it's about. I will put it in there. That either will be the next episode or it'll be 2 episodes, because another episode I want to talk about is the homeless situation and what we can do to help versus just putting up concrete spikes or putting up, barriers on the park benches so they can't sleep there. So those will be probably about the next 2. So, all right, I will see you guys next Thursday.